talk very briefly about what's new in preeclampsia, and I'm happy to report that for the first time in years of giving this talk, there are a few new things on the horizon. I'm not going to talk about all of them because I think some things are much more closer to the clinical interface than others. So I am going to talk a little bit about the Pelican study in PLGF, which I think will be appearing in a unit near you soon, if it hasn't already. And I'm also going to mention Improved, because that's my own study, and it's a trans-European study that is trialling what, if it works, will be the first test ever for the early detection or early first trimester screening for preeclampsia. But I'm mainly going to talk about Pelican because, as I say, I think that's far closer to clinical use. When we think about preeclampsia, the four things that I always think about are we any closer to actually describing what causes it? And I think I covered that this morning, and I think I kind of explained that whilst we have a kind of working model, it always reminds me of the Donald Rumsfeld kind of statement. You know, the guy who was Secretary of State at the time of the Iraq invasion, who said, there are the things we know, and the things that we know we don't know, and then the things that we don't know we don't know. And I think with preeclampsia, there's a lot of what we don't know that's still out there. And so that I'm going to park it there because I think what causes preeclampsia is there are theses in it. How to diagnose it and how to predict it are kind of almost wrapped up at the moment in the same conundrum, because I think for reasons that I'll explain when we see the Pelican study, diagnosing and prediction is all the same thing. The only difference is sort of temporal change. And then the holy grail, the obstetric holy grail, can we cure it yet? Is there anything we can do that actually will prevent it or cure it once it happens? Just a recap, and this is important because it actually matters when we think about how to predict or screen for preeclampsia. The basic pathophysiology resides in the placenta. I know we talked about the genetic influence and the immunobiology, but if you're looking for the causative organ, the roots of preeclampsia is in the placenta, and it helps if you have a maternal vascular endothelium that's already damaged. But that's kind of the perfect storm for the development of preeclampsia. And I showed you this slide this morning just to remind you that one of the complexities when we think about preeclampsia is that it's not the same disease. Just now, three of us were talking about our own personal experiences of preeclampsia. I was just sharing my 32-weeker story, who incidentally I've just had lunch with. He's a first-year medical student in Trinity now, but he was a 32-weeker preeclampsia abruption, very growth restricted, 7 weeks on the neonatal unit, chest drains, the whole works. And he was the classic, very growth-restricted baby with a placental abruption, and my preeclampsia, retrospectively, was quite mild. Versus Zoe's story, which was clearly the full whammy, the full complement, and Ali's story, which is more fetal growth restriction. The reason why I mention that is that there are different types of disease. It's the same disease, but it looks very, very different. And as clinicians, that's a problem. We like straightforward stories. We like black and white. Is it or isn't it? It's one thing or it's another. The fact that it does masquerade as so many different things and has so many different phenotypes is a problem. So how do we diagnose it? You remember this slide? They're kind of 1932 Jan Stone Dutch masterpiece of the typical woman in late pregnancy with epigastric pain, and the fact that back then we recognised that there was something in the urine. We couldn't actually measure blood pressure in 1732. We can now, but that's probably the only difference between then and now in terms of antenatal care. So one of the things that we've been striving for in the preeclampsia research community is better diagnostic tools. You might think, oh, that's really simple. You need is a sphygmometer and a dipstick to diagnose preeclampsia. But actually, when you think about real life, when you think about women who enter pregnancy with high blood pressure, when you think about women who have things like antiphospholipid syndrome, proteinuria in the background, women who come in with quite significant PIH but no protein, and you don't know whether they're going to be that 35% that progress to preeclampsia, diagnostic tools are important. And if you think about our day case units in the hospitals where we all work, I can guarantee today we'll have had 20 plus women in for blood pressure series, the vast majority of whom will have happy, healthy babies and will leave the hospital with no ill effect, but yet will have spent a significant amount of time in our day case unit reading Hello magazine and getting very, very bored at great expense to the taxpayer. So we've done a lot of work looking at can we actually get better at diagnosing and predicting preeclampsia. And all the things we've looked at are basically really poor. You don't need to look at this slide in too much detail. I put it up just to show that we have looked. People have actually done the research. And we've shown that things like blood pressure as an isolated predictive value is really poor. Blood pressure is a really wide, there's a lot of variety, there's a lot of background noise in blood pressure measurements. And the low likelihood ratios for prediction means that as a predictive tool, as an isolated predictive tool, it's really, really poor. Unless you've got a ragingly high blood pressure, it's useless for both diagnosis and screening. Similarly, proteinuria, which is something that as clinicians always freaks us out, again, limited clinical value when it comes to screening or prediction. It's actually quite a poor predictive marker of both maternal and fetal morbidity. Women with very heavy proteinuria can have actually relatively uncomplicated fetal outcomes, and that's been shown time and again. American researchers put a lot of faith in uric acid as a predictor of placental function and therefore the outcome for the fetus. Of the things that we've looked at, it's probably the best, but you're talking about the best in a really poor field of predictors. And an isolated uric acid as a one-off predictor of adverse outcome, again, has error margins around it, confidence intervals that are so wide it's not useful as a clinical test. And even if you combine all those things, as we do in all American, Canadian, UK-based classification and predictive symptoms or pathways, they have very poor clinical utility. And for every case that you might pick up, you will needlessly put anywhere between 10 and 25 women through high-risk screening for something that they're not going to get. And I'll show you why that is in a minute. And it's the same for the baby. Even using customized symphysis fundal height centile charts, we miss most SGA babies, even when we use customized centile charts. And that's only going to get worse as the population gets slightly more obese. IUGR is a significant cause of underlying neonatal morbidity and mortality, and yet we miss it. Some figures suggest that we only pick up 16% of growth-restricted babies. Using customized centile charts, we might pick up 75%. And I don't know if Ali Hunter covered this before, but Ali is passionate about the vulnerable fetus and the fact that we don't really have, despite the fact that we have the tools, we don't use them appropriately for screening for the at-risk fetus. One of the problems is that ultrasound is quite expensive. We work in an NHS and HSE paradigm, so we're used to having ultrasound, relatively speaking, at our fingertips. But in America, ultrasound costs anywhere between $500 and $700 a pop, and the insurers pay for it. And that's a lot of money, just on the basis that you think the baby might be small. And in Africa, where I've done some work, there's only one ultrasound machine for 25,000 pregnancies. So it's as cheap as chips. It only costs about $5 to do a scan, but that scan has to do for 25,000 women. So ultrasound is a significant, whilst the gold standard for picking up the fetus, there has to be, we hope, something that's cheaper and more robust and more widely available. And that thing, for a while, we've hoped might be placental growth factor. And I'm going to talk a little bit about this because I think whether we like it or not, and whether we believe in it or not, I think it will be coming to a unit near you very soon if it's not already. PLGF is one of those things that we talked about before that originates in the placenta and is altered in the serum of women with preeclampsia. In the case of PLGF, it's actually low in the serum of women with preeclampsia, and that's because PLGF is high in normal pregnancies. Healthy placentas produce PLGF. It's an angiogenic growth factor, which means it's responsible for the growth of blood vessels, particularly in the placenta. And if the placenta is faulty, the production of PLGF goes down. So unlike other things we've looked at, PLGF is low in the serum or plasma of women with preeclampsia. And for about the last 10 years now, there's been a lot of commercial and research interest in both the diagnostic and predictive value of PLGF in preeclampsia. This is a paper that was published exactly 10 years ago now, and it's really a landmark seminal paper that was published in the New England Journal by Anath Karamanchi and his group from Harvard in the States. And they showed very convincingly that if you track PLGF through pregnancy, and here you can see these are healthy pregnant women, the blue lines are healthy pregnant women, and the women, or the line in red, is women who ultimately get preeclampsia. But if you track their PLGF levels from very early in the first trimester throughout gestation, you can see that consistently, and from about 17 to 20 weeks gestation onwards, PLGF levels are lower in the women who subsequently get preeclampsia, regardless of when they get it. And you can see here that if you measure PLGF at the time that preeclampsia is actually diagnosed, it's very, very depressed. So this little black line here in this original paper from 10 years ago was women who tipped up at the labour ward at 29 weeks with raging preeclampsia. And they had their PLGF levels measured and they went down here right at the bottom. So this sparked a huge amount of interest in PLGF. What I just want to draw your attention to is that PLGF levels fall even in the normal pregnant population from about 32 weeks onwards. Okay, and that matters because that makes it more complicated if you're looking at PLGF in late pregnancy. And late pregnancy, unfortunately, is when most cases of preeclampsia present. But nevertheless, there's been a lot of interest in this. And what we've really been looking at is the value of PLGF at this crucial time in pregnancy, at the 29 to 32 week mark, whether PLGF at this time in pregnancy has predictive or diagnostic value for subsequent outcomes. So, there are three big diagnostic companies who were interested in PLGF, Roche, Perkin-Elmer and Alea, and you've probably all heard about them because they've all got very aggressive reps that go around all the hospitals peddling their different assays. But of the three companies, Alea have probably taken the most intelligent route to market. And by that, I mean they've actually engaged with their end users. They've engaged not only with clinicians, but critically, they've engaged with women. The women who actually come through the day case unit and who come through the hospitals. And I've asked women, what would make a difference to you? Do you like being attached to a sphygmometer for 6 hours a day, every second day from 32 weeks onwards because you've got essential hypertension? Or would you like a blood test that can actually free you from the tyranny of that for maybe 2 weeks at a time? And they've listened to all their key stakeholders. And the result of that, plus a lot of in-house research, is this, the Alea triage assay. The triage platform is this little thing. It's the size of an old-fashioned desk telephone. For those of you who haven't seen it, it looks like an old-fashioned desk telephone. It's about the same size. And it's a point-of-care device. So it's meant to sit in the day case unit or on the ward next to the colorimetric meter you might use for urine dipstick analysis, or next to the computer. And the basic idea is that you drop, a bit like a pregnancy test, you drop a few mils of blood here. Rather than urine, you drop blood. You stick the cartridge in the meter, and 15 minutes later it spits out via like a till receipt, and it looks exactly like a till receipt or a credit card receipt. It spits out the PLGF level. It's fully quantitated, so it actually gives you the exact amount of PLGF in the blood. And there are various other things about it that make it quite a good assay. It's very specific, it's highly specific, unlike some of the other assays that are available. It picks up a huge range of PLGF from almost the unmeasurable right up to 3,000 picograms per mil, which is a lot of PLGF. At the moment, and unfortunately for the last little while, it's only been able to run on plasma, which means if you take a sample of blood from the woman, you have to spin it before you can actually use the triage test. But they promise us, and bear in mind there's a caveat here, they've been promising us for 2 years now, that it will be whole blood capable soon. I think it's a little bit bogged down in FDA, Food and Drug Administration, US approval processes at the moment. But the idea is that it will be whole blood, which means that within 15 minutes of doing a blood draw, if you drop a few bits of blood onto this cartridge, stick it in the machine, you'll get a robust and reliable PLGF quantification. So, why does that matter? Well, there's a whole heap of work that's been done over the last little while that shows that PLGF actually is a very good predictor of bad outcomes. If you have a low PLGF, your pregnancy is not going to do well. And exactly how bad the pregnancy does seem to correlate with the actual level of PLGF. I've summarised all these trials here by the name of the first author, and these slides will be available for anyone who wants them afterwards. But the bottom line is that they're all pretty much the same. They show that if you have preeclampsia at the time, or if you present with query preeclampsia and you have a PLGF level done, and if that PLGF level is low, your outcome is not going to be good. And we've got some precise quantification around that in terms of sensitivities and specificities and what that actually means. And this is just slightly more of the same, but it shows some of the fetal outcomes as well. So you can see that it's highly predictive of small babies, estimated fetal weights and abdominal circumferences of less than the 10th centile, and in this case, less than the 3rd centile, which are the babies that we do really very much worry about. So that prompted a group of us a few years ago to do something called the Pelican study, and this was published about 3 or 4 months ago, and I think it got quite a lot of lay press attention, certainly in the UK. It got into the Daily Mail, which is sometimes not a good thing, but in this particular case I think they did a reasonable job of reporting the significance of the story, and I'm just going to very quickly run through what the Pelican study showed. Remember this graph? This is the Anath Karamanchi-Levine paper from 10 years ago, which shows that PLGF is consistently lower from early in pregnancy all the way through to term in women who are destined to get preeclampsia. So what the Pelican study set out to do was to examine whether PLGF levels in women tipping up to the day case unit or your antenatal clinic with suspected but not yet confirmed preeclampsia was predictive of final outcomes, final diagnosis and final outcomes for mums and babies. And we also looked at different gestational groups. So we looked at the preterm, the kind of near term, and the term preeclamptics. Preeclampsia was defined according to standardized recognised criteria. It was a large study done in 7 UK and Republic of Ireland tertiary referral centres. And the criteria for taking part in this study is there had to be someone in the house who had an interest in preeclampsia, because the management of women with preeclampsia is slightly controversial and not everyone does the same thing. So the study was set up to look at 7 like-minded consultants who would manage preeclampsia in a relatively uniform way. So there were 7 units ultimately that took part. And as far as women were concerned, you just needed to be over 16 and eligible to consent. It was a high-risk, low-risk mixed parity study, so there were very few exclusion criteria. PLGF was measured at the time of initial presentation, and if the women returned to the day case unit with suspected preeclampsia on numerous occasions, they were resampled. Lots of data had suggested that you could draw a percentile chart of PLGF, and if the PLGF was less than 12 picograms per milliliter, that's beyond the limit of detection of the meter. So if your PLGF is less than 12, the meter can't actually see, the test can't actually detect PLGF. So that's lower than the meter can actually pick up. PLGF, almost negative as it were. And in previous studies, a very low PLGF, a highly abnormal PLGF like that, had been associated with an extremely high risk for adverse outcomes within a 2 to 3 week period of that level. Whereas PLGFs over 100, which is the 5th centile, so PLGFs in the top 95 centiles or greater than the 5th centile, was actually associated with a very low risk for adverse outcome. Given the very wide dynamic range of PLGF, that's a small window. 5 to 100 picograms per milliliter is actually quite a small range. So this is just some of the data. I won't go through these in too much detail because there's a lot of data and it's all in the public domain now. But we actually recruited 625 women in a very short period of time through the 7 centres. We had a few missing bits of data. And women were at every gestational age group. So we had 287 women who were less than 35 weeks, some women in the near-term group, 137, and 200 women in the term group. And if you look at the number of women who delivered preterm or who had SGA, and also particularly those women who had stillbirths, this was an incredibly high-risk group. Now, these women are coming to our day case unit with query preeclampsia. They're in consultant-led tertiary referral units where there is recognised expertise in the management of preeclampsia. And yet in this group of less than 700 women, we had 9 stillbirths. Okay, that's more than 1 stillbirth for every 100 women. So they're a very high-risk group indeed, and that's despite our expert management. And this just shows some of the patient characteristics. As you might expect, they are a slightly older demographic. They have a slightly higher BMI. They are more nulliparous than multiparous. And we did include twins, although we haven't actually done the sub-analysis on that data yet. And they presented with typical things. New onset of hypertension, all the things we usually see on the day case unit. New onset of hypertension, headaches, abnormal fetal growth, and new onset of protein. As you might expect, the fetal characteristics were significant of the high-risk cohort that we were looking at. They, in general, delivered preterm. They had a decreased birth weight centile, a lot of SGA, the 7 stillbirths in the, this is it just in the less than 35-week group, there were 7 stillbirths. They had a high rate of intervention, a very high cesarean section rate overall. This is the curve that we generated from previous data, but also was shown to be true for Pelican. This is the area under the curve, which shows the predictive values. And this is the rule-out diagnosis. So this is where the 100 picogram per milliliter level is. So basically, if you are under the curve down here, then you have a normal PLGF. And conversely, if it's less than that, you have an abnormal PLGF. And these are some of the data that shows how it performs. So did the test correctly identify or exclude disease? So this is a woman who turns up at the day case unit at any gestation with signs and symptoms of preeclampsia. And if her PLGF was abnormal, what was the sensitivity and specificity? Well, if your PLGF was abnormal, it was highly significant of needing to be delivered for any reason, whether it was maternal or neonatal, within a 14-day period. And I'll show you some exact data on that now. So if you had a highly abnormal PLGF here versus the normal PLGF over here, your hazard ratio, your risk of being delivered within a 14-day period was 22 times more likely to be delivered for any reason within a 14-day period of that initial abnormal result. So a highly abnormal PLGF is a very strong predictor of needing to be delivered preterm. We didn't specify why. It might have been, and this is one thing that we need to look at, it might have been because clinicians were just a little bit jumpy and wanted to jump in and deliver the fetus. But in this study, clinicians were actually blinded to the result of the PLGF. So no clinicians were aware of what the result was. This was a post hoc retrospective analysis. So in all these cases, clinicians were monitoring the pregnancy blind of what the PLGF was. That led us to be able to look at the prognostic performance of PLGF, and you can see here that you can actually band it into, ignore the top one, you can actually band it into traffic lights. So we have a normal PLGF, greater than 100 picograms per milliliter, one that's in the amber zone, so it's higher than the limit of detection but less than the 5th centile, and then this highly abnormal level where you can't really see PLGF in the sample. And you can see the time to delivery along this axis here. If you have a highly abnormal PLGF, less than the limits of detection, you were very, very likely to need delivery for whatever reason within 14 days. And some of these women had PLGFs done as early as 20 weeks, don't forget. So this is a significant positive predictive test. Similarly, when you look at the amber, the abnormal test, you can see that women were certainly delivering a lot earlier, although in some cases the span of delivery was as far, I think the median was 29 days in total, so you were likely to be delivered within 29 days of the abnormal test, whereas women who tested normal, they were likely to deliver at or close to term. That's led us to develop this clinical management algorithm of how to use PLGF at the point of care. Clinicians are really simple creatures. We like traffic lights. We like red, amber, or green. Green, go back to the community and don't darken our doorstep again. Amber, we need to see you again on the day case unit next week. And red, you need to come into hospital. And that's an oversimplified version of the algorithm, but it's reasonably accurate. So for women presenting with pre-eclampsia and a PLGF of less than 12 picograms per mil, we, on the basis of what we've already described, would now advocate inpatient management. So high-level care, possible admission depending on the geographical proximity of the patient to the hospital. For medium-risk women, they need to continue under high-risk outpatient observation, so coming back to the day case unit for frequent maternal and fetal surveillance. But if they have a normal PLGF, their outcomes are, certainly as far as we can tell from our current study, uniformly good, at least as far as preeclampsia and fetal growth restriction are concerned. So they can continue with a normal pattern of antenatal care. I should say this hasn't been trialled in an RCT yet. We are trying to trial it. We are trying to get funding to trial it. And we have certainly in Ireland, we have an application under review at the moment with the HRB and an application in the UK under review at the moment with the Tommy's campaign, and hopefully we'll be able to join forces and do a properly trialled RCT, which will evaluate how it performs when you actually put clinicians into the mix. One thing we can't control for are clinicians, and clinicians, our worry with PLGF is it will become the 21st century CTG. It will become a test that's not been validated, never properly been trialled. We'll roll out on our day case unit and people will start delivering babies preterm on the basis of a one-off abnormal PLGF and fill our neonatal units with preterm infants with a test on the basis of a test that hasn't actually been fully trialled yet. The company who sponsored Pelican, Alea, are a very good company to work with from a research perspective, but they need to see money out of this now. They've invested millions and millions in R&D and they are aggressively marketing it. I know for a fact it's certainly being used in 3 or 4 centres in Ireland at the moment, and it's been used in 4 or 5 big regional referral centres in the UK in the absence of an RCT. There are a bunch of us who think we really should stop right now and trial it before we go any further with this test. But market forces are market forces and we may not get the chance. So can we predict preeclampsia? That's diagnosis. That's at the time women tip up to the day case unit or to our antenatal clinic with query preeclampsia. But what we've all thought of for a long time as being the kind of real goal is the prediction of preeclampsia in early pregnancy. Because now we know what we know about aspirin and calcium in calcium deficient populations, and there are a few other things coming on stream, novel treatments for preeclampsia, potentially like sildenafil citrate, commonly known as Viagra. These are all novel things that are in the pipeline at the moment. But if I went into my antenatal clinic on Monday next week and said to someone who was at even moderate risk of preeclampsia with, say, a 10% risk, I'd like you to take Viagra from 12 weeks of pregnancy until 36 weeks, please. She's not going to say yes on the basis of a prior risk of 10%, because we don't know what Viagra does in normal pregnancy, and it might be beneficial in preeclampsia. But even if we prove that, we're going to need to test to screen out those that really need it. So prediction of risk is incredibly important. I'm going to whiz through these few slides because essentially it's a negative finding, but we've been doing something called the SCOPE study I mentioned it this morning, in Cork and in the UK, Adelaide and Auckland for quite a long time now, for about 10 years. This has been a decade of hard work and collaboration to try and build a biobank and develop early pregnancy prediction tests for preeclampsia and other things, but the main thrust has been preeclampsia. And I think we recognised a long time ago that preeclampsia is a heterogeneous disease, and it's unlikely that one biomarker is going to predict preeclampsia, and it's likely that we'll need more than one. A biomarker that might work for very early preeclampsia with fetal growth restriction may not be the same biomarker that predicts women who get preeclampsia at term. And so the whole basis behind SCOPE was to join forces and develop a big biobank. The SCOPE study cost somewhere in the region of $6 million just to collect the samples, and probably another $6 million in infrastructure to store them and pay the salaries of the people who collected them. It was initially designed to collect samples from 10,000 women, but it was underfunded and stopped short of that with about 6,000 women in the biobank. And the study closed out about a year and a half ago. It consists of samples, it consists of 6,000 women who are nulliparous and low risk, who gave samples throughout pregnancy and stayed within the study until they completed their pregnancies. And we've got about 2,400 data points on every woman. We've asked them everything, from how many times a week they had sex before they took part in the study, to whether they ate broccoli. I mean, there's no question yet we've been asked about these women that we haven't already asked them. It's a very detailed biobank. And this is just a screenshot of the interface, and this is a screenshot of the samples that we've taken. We have over 1 million aliquots of serum, plasma, DNA, urine in all the different freezers throughout the world that consists of the SCOPE biobank. Just some clinical data. So this is a low-risk nulliparous population, and you can see that in this low-risk nulliparous population, we had a 4% incidence of spontaneous preterm birth, overall a 5% incidence of preeclampsia. That's slightly higher than the 3% that's generally quoted in the textbooks, and that probably reflects changing demographics, older women, slightly more obese women. We had an 8.4% risk of gestational hypertension and an 11% risk of SGA. Early preterm preeclampsia, those women who required to be delivered before 34 weeks because of their disease, quite unusual indeed, only 0.5%. And that matters because we actually had nearly 6,000 women in the SCOPE biobank, but only 28 cases of early preterm preeclampsia. So when it comes to actually doing research, this is incredibly expensive. If you're looking for early pregnancy samples from someone who develops preeclampsia at 29 weeks, you're going to need to collect a lot of early pregnancy samples just to collect one case. And that's one of the challenges of doing preeclampsia research. And then just some interesting thing from a clinical perspective. We've all sat in the clinic and we've seen the woman with a BMI of 40 and a booking blood pressure of 150/90, whose mum died in childbirth of preeclampsia and whose sister was on the neonatal unit only 4 weeks ago with HELLP syndrome and a preterm baby. And we've all thought, you are going to get preeclampsia. We've all been there, and I've certainly done it myself. And yet she sails through pregnancy and is completely fine. And the reason for that is that for every single clinical risk feature we've looked at in SCOPE and elsewhere, there are always far more many women who don't get the disease than who do, no matter what risk factor you look at. And that means that constructing a useful predictive model is really, really tricky. And I'll show it by just showing you the Venn diagram. So the 3 risk factors that we all associate with increased risk of preeclampsia: a strong family history, a high BMI, and a high booking blood pressure. So they're the three strongest clinical risk factors. And if you saw a woman in the clinic who had all three of them, you would be thinking, I don't know, but maybe a 50% chance of getting preeclampsia, something like that, if they had all the risk factors. In fact, the reality is completely different. This is all the women in scope who had those three risk factors: blood pressure, BMI, and family history. And you can see on the top line, women who didn't have any, they had no blood pressure, no family history, and they had a normal BMI. They were far and away the largest number of women who got preeclampsia. 37% of women in scope who got preeclampsia didn't have any antecedent risk factors. And if you look at the women who had every single risk factor, they had a high BMI, a high booking blood pressure, and a strong family history, they're a minority of the women who get preeclampsia. And overall, only about 26% of them get preeclampsia in any way, shape or form. So that just shows that clinical risk prediction is really pretty rubbish. And we're going to need something stronger. These are just some plots that illustrate. These are women plotted according to blood pressure, and you can see along the bottom here, these are women who do get preeclampsia, but in every single cell count. And if you look right up at the top here, right up at the high end, where you've got very, very high booking blood pressures, you can see that women who don't get preeclampsia is still the overwhelming majority of women in that particular group. And no matter what you look at, it's the same and same again: blood pressure, BMI, and so on and so forth. We tried to be really clever. We had all this data in scope. We had diet, family history, father's history, sexual preferences, the whole works. So we decided to be really clever and see if we could use some of the novel data to build a better model. We published this in 2011. Robin North and myself and all the other researchers in scope. And I won't bore you with the 3.5 years of number crunching that we did, but the answer is no, it doesn't really work. We have an area under the curve of about 0.71, and just to illustrate what that means, if I had blood pressure alone, just blood pressure alone, I could predict with an area under the curve of about 0.62, 0.64. So all the 2,400 data points we had on every single patient didn't really get us much further towards the line. And where we need to be at is an area under the curve, well, as close to 1 as possible, but certainly over 0.9, 0.95. So on clinical risk prediction alone, we're a long way from where we need to be. So scope basically taught us that we do need biomarkers, and at the same time we were doing scope, we were doing Pelican, so we decided to look at whether PLGF plus other biomarkers might, if they would work at 15 weeks. Biomarker work is really expensive, so we teamed up with our favourite company again, Alea. They do have a vested interest in this area. But Alea very kindly provided a list of over 100 biomarkers that they had in-house, proprietary and generic biomarkers, including PLGF. They took a whole bunch of us to Rome. We met, we looked at the literature, we constructed a short list, a long list, then a short list, and eventually decided which biomarkers we would look at in scope. And we looked at 47 in total. And we looked at them all at 15 weeks to see if any single biomarker or any combination of the 47, including all 47 biomarkers, if they would help predict preeclampsia at 15 weeks. This is just, we split the cohort, so if we split them into two sets, so we look for biomarkers in one half of the cohort, and then to see if they were actually real, we looked at it again in the second half of the cohort, a sort of training and validation aspect. These are some of the things we looked at. These aren't important, but you can see some of the usual suspects we've talked about, like PLGF. PLGF, interestingly, is very predictive of early preeclampsia, but when we looked at it to see whether it picked up preeclampsia at term, it doesn't pick preeclampsia up at term at all. So if you get HELLP syndrome at 40 weeks, the likelihood is your PLGF will be normal in early pregnancy. There were some other novel things that we looked at, some things that popped out that have been in and out of the literature and in and out of favour over the years. People have had Nature papers published and rescinded on some of these biomarkers over the years, but we looked at all of them. And in every combination, we looked at all of the biomarkers together, independently, in different groups, and we also combined clinical data, including blood pressure and BMI, to see if we could get anywhere near something that was useful. Now remember what we said, we need to be preferably as close to 1 as possible, but the bare minimum we really need to be at to introduce a test into clinical practice is certainly over 0.9 and preferably over 0.95. And as you can see from these figures, we're nowhere near there. Unfortunately for preeclampsia, for all preeclampsia, the figures are incredibly disappointing. And every combination of really expensive biomarker assays doesn't significantly increase the area under the curve from where we were at in 2011 with our BMJ paper with an area under the curve of 0.71, using a test that costs somewhere in the region of about $900, we get to 0.73. So biomarkers, unfortunately, in early pregnancy are not going to predict preeclampsia. They were slightly better at picking up the early onset preeclampsia, so these are women who deliver before 34 weeks, but these are a minority of the women that we see through our unit. So in terms of bang for buck and whether it's economically viable to roll a test out, this is a small, it's not where the burden of disease lies. So can we predict preeclampsia? We think probably not at the current time. We think that the best model at the moment would be to use something like the SCOPE or the Precog guideline to pick out those women who are at high risk in early pregnancy and give them aspirin. We give aspirin to just about anything that moves in medicine at the moment. If you've had a father's relative who died of a stroke, the likelihood is your GP will have you on aspirin from a very early stage. And it looks like it has a very well tolerated and low risk risk profile. And there are some people, including good friends of mine, who think we should give every pregnant woman aspirin no matter what her prior risk is, because it's as cheap as chips and we seem to be a long way yet from a screening test. And even if it only reduces the burden of disease by about 18%, that's still 18 women out of every 100 who won't get preeclampsia because of the use of aspirin. I'm slightly more pragmatic. I think that's over-medicalising what is happily for most women a normal physiological event, and that we actually shouldn't give up the ghost just yet. Just because it's hard doesn't mean it can't be done. So we're advocating some sort of clinical risk-based screening in early pregnancy with or without PLGF to pick up early onset disease, and aspirin for those who are at increased risk. And then potentially screening everyone again at 32 to 34 weeks with PLGF. Alea, the company who've developed it, would love us if we actually managed to really strongly advocate for that, because they'd be onto a winner. But I think from our perspective it would save it would potentially make big economic sense when you think about how our day case units are filled day after day after day with women coming in with spurious symptoms and signs who we all strap to blood pressure monitors and do urine tests on and other blood tests for preeclampsia, knowing that the vast majority of them are fine. But because we've all seen women like the ones I presented this morning, like the cases I presented this morning, we do it. So we're not quite there yet. So if plan A didn't work, there's lots more letters in the alphabet, and that leaves us to improved. This is the study that we have just these last few months, started in 6 European countries. It's a FP7 funded study, which is looking at the capacity of really high-tech metabolomic profiling to predict preeclampsia. So this is a test that's based on personalised profiling. It involves taking blood samples at 15 weeks and looking at up to 15 small molecules in maternal blood to see if we can profile women, a bit like CSI Miami. We use the same kind of technology that they use in CSI Miami in the forensic lab, but we're looking for rapid sequencing metabolites which change from an hour-to-hour basis in the serum. Our preliminary data is really good, it's exceptionally good, but I think I've just seen too many false dawns in preeclampsia research to get too excited about it. So rather than actually do a small-scale clinical trial, we've decided to do a phase 2 cohort study, which means that we're going to collect samples from 5,000 women, not tell the clinicians, test the samples retrospectively, and evaluate whether the test works in-house before we try and unleash it on a proper RCT. We'll have that data in 2 years. So if I'm lucky enough to get invited back to APEC in a few years' time, I'll be able to show you that data. So that's a rapid race through what's new in preeclampsia research at the moment, and it's impossible to thank everyone who's taken part in this work and other work I've been privileged enough to take part in, but these are just a few of the people that I've collaborated with very happily over the last 10 or 15 years, and I feel I should definitely point out Robin North, who's here. Robin is a professor, she's an obstetric physician, a professor of obstetric medicine from Auckland, who really inspired SCOPE, and just about everybody who's working in modern day preeclampsia research owes a debt of gratitude to Robin for being so clear-headed and putting us on the right path with regard to biomarkers, prediction and screening as a whole, and obviously our funders, including Leah. So I've got a few minutes for questions if there are any, and I do apologise for eating into your coffee break, but I'm on call in Cork at 8.